Thank you. Let me introduce today's panelists. One panelist, of course, our esteemed Professor Suhail Aziz. I don't want to call him Professor Suhail Aziz as against Major General. That sounds more like academic. And Professor Ishaq. We all know Professor Ishaq, and Ishaq is the chief convener of FCPS examinations. So he'll be giving his perspective from that. The speaker for today is Professor Khawar Kazmi. We all know him very well. He's one of the true researchers, and this is in inverted commas, in Pakistan, who has contributed immensely by participating in all Salim Yusuf's projects, starting with INTERHEART study and now with the study of anticoagulants. He has been into school health studies, and he has also taken upon himself to promote prevention, and he now heads the Department of Preventive Cardiology at National Institute of Cardiovascular Disease. We are all very proud of NICVD, our premier institute. So we are very grateful for Khawar to, in spite of his very busy schedule, he took upon himself to present to us dyslipidemia and CVD prevention. Over to you, Professor Khawar Kazmi.
Thank you, Hafiz. बहुत शुक्रिया and Assalamu alaikum everyone. Especially Ishaq Saab, thank you very much for being with us, and Major General Suhail Aziz. Leto, I think it's a very good initiative, and Hafiz has always been leading in academic endeavors, and we wish him success, best wishes, all our support. I was stressing, मैंने कहा I think Saturday है थोड़ा light रखना चाहिए, तो I'll have a mix of English and Urdu in presentation, and पहले ये कहते कि national lipid program जो है वो I was पहले थोड़ा सा was stuck. I hope it's not NLP बनता है, not TLP, so कल था कि चले थोड़ा बचत हो गई. I mean at least it's not TLP. So okay, anyway, I would start. I think prevention के हिसाब से, I think one of the things which we all talk about is, and Hafiz mentioned that in my introduction, is INTERHEART, and that's where I would start. But I think first the MCQs which are related to my presentation today that I can post, and all the attendees, they can think of the answers and keep it with you, and then at the end of the presentation they can see whether, most likely, I mean most of you will be right, so you can just mark full marks for yourself. So first MCQ is about the INTERHEART study. It was a landmark study, but there was also a South Asian paper from INTERHEART study, but that is not talked about as much even in Pakistan as we probably should have been. So the question is related to that in South Asians, the first AMI age was significantly younger to the Western population or rest of the population in INTERHEART study, and the South Asian paper did suggest the possible explanation of that. So what was the possible explanation? The risk was largely explained by genetic predisposition, or higher tobacco use at younger age, or higher levels of INTERHEART risk factors at younger age, or low levels of physical activity. So this is one best answer. So you can mark your answer now on this MCQ. I'll go on to second MCQ, and Hafiz, if there's any point where you want to add anything, you please do that in between. Okay, second MCQ is about the ESC guidelines on CVD prevention, which were released last year, 2021. So the question is that what is the ultimate target for LDL cholesterol for apparently healthy person under the age of 70 with high risk level? Is it 100 milligram or lower? Is it 55 milligram or lower? Is it 70 milligram or lower? Or is it 70 milligram or lower, but not lower than 40 milligram? So this is the second MCQ. So you can note your answer on this MCQ, and we would start with the presentation now. So I'm going to talk about INTERHEART South Asian part first. The South Asian contribution was from India, Pakistan, Bangladesh, Nepal, and Sri Lanka. And it was my honor and privilege to be part of this study from Pakistan. Pakistan made a big contribution in the whole South Asian part, actually the largest contribution. We had about 600 plus cases and 600 plus controls from Karachi, Hyderabad, and Islamabad. The 5 centers participated in that. I would talk about the age distribution in this South Asian cohort. And the 2 points which I would want you to notice is here, if you would say this is number of cases. So we'll see just overall cases. You will see the age, which is worldwide 58 and South Asian 53. So about 5 years younger than the other worldwide participation. This is all India, Pakistan, and same thing contributes. I mean, Pakistan was 53 years, same as the overall South Asian was. One interesting point, second interesting point to note here is number of cases which were under the age of 40 at this time. And this study was, I'll remind you, was done in late 90s, and enrollment was finished in about 20 years back. So this is about 20, 25-year-old data. And even at that time, if you would see that overall in South Asia, there were about 9% of cases which were under the age of 40. Same was true for Pakistan, about 9% cases. And if you would see only in men, there were about 10% cases which were under the age of 40. So significant number of cases. We still talk about, I mean, we are seeing young people under the age of 40. So even at that time, we had this problem. And this was analysis from the risk profile or from the South Asian cohort. And if you would adjust for age, sex, and all other things, after adjustment, the risk of probability of having an MI or and being under the age of 40 was very similar in South Asia and other countries. So the point here was that there is no other issue except that there is higher concentration of the 9 risk factors which is INTERHEART had studied in a younger population. So higher level of traditional risk factors in young age, which accounts for the early age of South Asians. So the second point I'll talk about a little later about lifestyle changes, but this was an important point which I wanted to make about the age. What were the risk factors which were studied in INTERHEART? As I was saying, there were 9 risk factors. Alcohol was one, but it was not relevant in South Asia because can I request everyone else to please mute their mics during the presentation? Thank you. So the 9 risk factors I was talking about were one was alcohol, which was not significant because of very low usage or reported usage in South Asia. So we'll take that out. So out of 8 risk factors, 2 are protective risk factors, exercise and use of fruits and vegetables. And out of 6 risk factors, which 4 are mentioned here, 2 other were waist hip ratio and psychosocial factors or stress. So if you would see here, and that's what I would want you to note here. The 2 things which I have shown here, cases, controls, odds ratio, and then PAR, which is population attributable risk. So if you would see in these four risk factors, which is ApoB, ApoA1 ratio, which is about the lipids, currents and former smoking, hypertension, and diabetes. The odds ratio was very similar in all the four: 2.57, 2.57, 2.92, 2.52, but PR becomes very different. 46 or 47 or near 47 here, 37 and 19 and 11. Why does this become different? What it shows is that at an individual level, the risk, if you would have an abnormal lipid, the risk of having an MI will be 2.5 times more. But why does it change into a higher population attributable risk is because of prevalence of a particular risk factor. So if there are more people in a population who have more dyslipidemia, then the population attributable risk will become higher. So the prevalence of risk factor would change the PAR here. So that's why the ApoLipo B A1 ratio was different, or lipid as a risk factor was different at a population level. This becomes an important point for prevention strategies when you talk about prevention at a, population-based level. I am going to just talk about the same point in Pakistan also, because whenever we talk about these patterns, we all keep on saying we don't have data from Pakistan, and that, I mean, kind of hinders us taking on strategies towards prevention or effective management, and we get away with doing what we want to do rather than an evidence based practice. But I think INTERHEART has clearly shown that South Asia is not very different from Western population as far as the risk profile is concerned, except the younger age and some of the differences which I've already mentioned. And Pakistan is also very similar to rest of the South Asia. And this is the point which is shown on this slide here. So in apolipo or a lipid abnormality, again, odds ratio and population attributable risk remains the highest compared to the other risk factors. So the point I was trying to make here is that dyslipidemia, when we are talking about causation of acute MI, there are these all 8 risk factors, 2 protective and 7 other risk factors. But lipid abnormality becomes a very important risk factor because of its prevalence, and when we are talking about population-based strategies of on prevention of cardiovascular disease. So but this point is also highlighted in the ESC guidelines of 2021. So this is an little check from those guidelines. And I don't think now there is any question about the LDL as a causation of atherosclerotic coronary artery disease. And I think that chapter should not be discussed or should be questioned that whether it is still causing or not, although I still know that some people do that. So LDL remains a very strong risk factor beyond doubt. And the points which are given here are important. One is that, I mean, we know that lowering of LDL clearly reduces the risk of atherosclerosis. There is no question about that. We will have to keep on talking about how much lower, and these guidelines clearly show that there is definitely clear evidence that lowering even up to 55 milligram per DL is absolutely safe. It does not cause any other problems or any abnormality or side effects as we were talking about. So it's safe to lower LDL, and more you lower LDL, the better response or better protection you would have. So the benefit as far as CVD risk is concerned will depend on 2 things. One, if you would start with in someone with a very high CVD risk, if you would lower LDL-C, you will see a significant benefit. Even if the lowering of LDL is not significant, even a small lowering will give you a significant benefit. So we should try to lower LDL irrespective when the risk is very high. But the other thing which is important is if you would want to see full benefit, you will need to lower LDL to a level which is recommended, which is up to 50, like, I mean, recommended here up to 55 milli, is safe to lower up to 55 milligram per DL. Another thing which is now, I think, new and we need to clear, because we keep on talking about what drug and what drug we need out of statin we want to use, or other non-statin drugs, or what dosage we need to use. So it does say that it doesn't matter what drug you are using. It doesn't matter what dosage you are using. What matters is whether you are lowering cholesterol, LDL cholesterol or not, and what level are you achieving. So that is what is important. So we need to know what level we need to achieve for any particular individual when we are lowering LDL. Not really worried about what drug and what dosage are we using. This is another important point which wanted to make before we go on to CVD prevention, is about non-HDL cholesterol. As I had mentioned that in INTERHEART, we had studied ApoLipo-B ratio rather than an LDL cholesterol. Although I mean, there are many studies which have shown that LDL is the culprit, and that's the target which we normally use when we talk about prevention. But non-HDL cholesterol become even better measure, because it encompasses all atherogenic or ApoB containing lipoproteins. So if we would measure that, then we do not have to worry about what the HDL level is, whether it is lower or not, because we keep on talking that in South Asians, we keep on seeing this, in Pakistan, we keep on seeing this issue where HDL is significantly lower, and that's an important type of abnormality which we have in our population. So for our population, I think it will be much better if we would be calculating this non-HDL cholesterol. And there is no big rocket science behind it. It's just total cholesterol minus HDL, and that is your non-HDL level. But what non-HDL level we need to achieve? It's LDL goal, whatever you want to achieve. Whether, like, I mean, if it is 70, goal is 70. For LDL, for non-HDL, it will be 70 plus 30, which is 100. So whatever your LDL goal is or target is, you add 30, and that will be your goal for non-HDL cholesterol. So this will be, I mean, this is something which we should bring in our practice, to use non-HDL cholesterol more often than LDL cholesterol. Okay. So this was a conclusion which I've already shown, and we talked about the first point and second point. This was published in the original paper from INTERHEART was published in 2004, and the South Asian paper in 2007. And at that time, we did say that if we would make lifestyle changes early in life, that will significantly reduce the risk of AMI in South Asians. But unfortunately, I don't think we really achieved that. We talked about that, but we never could achieve those points. And that's why today I think South Asia is the epicenter of cardiovascular diseases. Uh, we have, I mean, South Asians are 23% of the world's population, but 60% of global burden of heart disease in South Asia, 58% of total CVD deaths, and unfortunately 40% higher MI mortality. In Pakistan, I think as we keep on talking, we don't have really good epidemiological data. This is an estimate from WHO, and the latest data was released in 2018. So it is a little old, and the numbers will be significantly maybe higher, because even if you would see here that in 2 years there was 61% increase in cardiovascular deaths. So this is a dramatic increase. I mean, whatever estimates we had for next 20-25 years, it has happened in 4 or 5 years. Same is true for diabetes. We all know, I mean, the diabetes percentage or number of patients with diabetes has increased in Pakistan in 2 years by 150%. So there's a dramatic increase in number of cardiometabolic disorders in Pakistan. So clearly, I mean, there is no question, and I don't think I really have to show any evidence that prevention is the way to go. Uh, uh, what are the types of prevention which we talk about? Primordial prevention, primary prevention, and secondary prevention. What is primordial prevention? Primordial is when you try to prevent even the risk factors to happen. So, like, I mean, what are the risk factors for cardiovascular disease, like, say, dyslipidemia or hypertension? So, you want to prevent even dyslipidemia or hypertension to happen, but that will have to be happening in those people who are absolutely naive to all these risk factors, young people, teenagers, or even school-going, age-going children. For that, I mean, because convincing anyone who is absolutely healthy to make changes in their life or for a healthier life in future is not easy. You need to bring in behavioral changes, and that only happens when you empower them through proper knowledge and education. And for this purpose, I think one very important point I think we have to have in Pakistan is that we have to have a uniform message, and from all forum for every one of us, we have to be saying the same thing rather than a difficult thing. Like in dyslipidemia, we tell our patients that your LDL cholesterol has to be at 100 milligram, and someone, I mean, even in our physician community, would tell them, well, your cholesterol is too low, so you can cut down on the dose of your lipid lowering agent. I mean, that's kind of a confusing message, and we should be clear that we all giving same message so that people don't get confused. So uh, prevention is a primordial prevention, as I was saying, is, I think it's tempting, but it's not easy to do. The reason it is tempting is because, I mean, as they say, it's a prevention paradox, that if there are large number of people exposed to a small risk, that would create a large number of cardiovascular cases compared to a small number exposed to high risk. And this is unfortunately a limitation of we all clinicians, that we are more kind of attracted or tempted towards our patients, which is high risk. I mean, those people who are already exposed to high risk. Even if we prevent cases there, I mean, it does not make a large impact on population, as it is shown here, that even a small change in blood cholesterol or blood pressure would make a significant change in the number of individuals, rather than just treating high risk individuals. But it is a daunting task, I mean, for primordial prevention, because changing behavior is never easy. So coming on to the second type of prevention, which is primary prevention, which means that you trying to prevent occurrence of cardiovascular disease in those people who already have some risk factors. So it could be community based or a selected community based, which I say high risk. Like you go to a general community as a whole, versus like you go to a particular set of community, like only men. You can decide that in a particular community you only want to check, uh, because I mean, obviously for prevention you will first have to be screening people. That how would you know that who are the people who have high blood pressure or at a risk of having high blood pressure or dyslipidemia or having a risk of cardiovascular disease? So, I mean, for screening, you could have either a particular group or a general community. and I'll talk about it a little bit more. The other possibility is that you have systematic versus opportunistic screening. Systematic is when you design a plan to go into a particular community and then screen whatever you had decided, like say everyone above the age of 60 or everyone above the age of 40, whatever you have decided. Whereas opportunistic screening is whenever you encounter a person, you do that. But this has to be a planned also. Holding a camp where people come on their own, that's not really truly an opportunistic screening, because there is a lot of bias on people who are coming to attend those clinics. Opportunistic screening will be that everyone who's coming for, say, a fever or a headache or upper respiratory infection in a clinic, I would check blood pressure of every one of them, and that becomes an opportunistic screening. This is a very important tool, and actually, ESC guidelines suggest that opportunistic screening may actually be more cost effective. But for that, you have to be, I mean, unfortunately, our lot of clinical practice or healthcare is not kind of as streamlined as it should be. But if it is, like, I mean, we could plan that in a particular area with the general practitioners in those areas, we plan this kind of an opportunistic screening. The point on community-based versus high-risk approach, I would want to share this points from ESC guidelines of 2021, which did suggest that if you have a structured national level program or a community-based or general program, it does increase a control of risk factors, but whether it reduces outcomes, we are not absolutely certain. High risk strategy obviously seems to be most cost effective because we know that it would certainly reduce CVD events. So, I mean, I think there are pros and cons on both sides, and there are debates on both sides. It depends on what kind of resources you have available to go on with the prevention strategy. Also, risk assessment, it doesn't have to be one point. I mean, you have to have a regular surveillance system. How often do you screen them again? Again, we don't have any particular definite data that what is a useful strategy. It has to be tailored according to whatever available resources are available. Okay, now the last point, secondary prevention, and that's something which very will should be, I mean, very close to all the clinicians who deal with patients with acute MI or those who already had a cardiovascular event, whether we are interventional cardiologist or a non-interventional cardiologist. We clinicians all see these patients, and it's our duty to actually know about secondary prevention and play our role in secondary prevention, because it is important to do secondary prevention also, because there are significant number of people who would have events, a second event after a first cardiovascular event. And so I say, I mean, if a patient who had an MI or a stroke has an MI again, it's a failure of our system or of us, and we should be very careful that we are playing our role so that this does not happen. And if we can prevent the second or subsequent event, we will reduce significant burden of cardiovascular disease in the community. What secondary prevention strategies we have to do? Obviously, I mean, we all know about aspirin, statin, ACE inhibitors, and beta blockers, and the lifestyle interventions. But unfortunately, as far as the usage of these therapies or drugs are concerned, this is data from Pure study, and I have a privilege to be part of this study. Also, Pakistan is also part of this study in a low-income country categories. And as you would see here, that the tallest bar here is the one with no drug. So 80% of people who already had an MI or a stroke in this population, which was studied in Pure, were not using any of the four drugs like aspirin, beta blocker, ACE inhibitor, or statin. So the usage after an coronary artery or event or a stroke, the usage of secondary prevention therapies is very, very low in our population. This is a recent paper and very interesting, I think, published last year in Frontiers in Pharmacology. And this not we normally read in cardiology because we won't be reading pharmacology journals, but very, very important thing. And that's why I wanted to share this paper. This is a national survey, and I think University of Punjab, then a couple of other universities from Karachi, Islamabad, Lady Reading Hospital, I think, was part of it also from Peshawar, and a university from China. They were basically behind this survey, which was done in about 40 public sector hospitals and 40 private pharmacies, 8 cities of all 4 provinces. So it was Lahore and one other city from Punjab, then Peshawar, Abbottabad, Islamabad, Karachi, Quetta, and Azad Jammu and Kashmir. They checked the availability of cardiovascular medicine in public sector and private sector. So the conclusion was that CVD medicines availability was significantly lower in public sector hospitals. Cardiovascular medicines were found to be unaffordable with average NDW of 6.4 for OB is the original brand. So that's the original brand which we normally see, like in statin, Lipitor will be the atorvastatin. Lipitor will be the original brand, and lowest LPG is the lowest available generic. So the other brands which are available, so this is the lowest price generic. So 2.2 NDW is the number of days of wages, so the number of days of work wages, which they calculated on the basis of lowest paid government employee. So whatever grade that is. So if you would be buying an original brand, you will be, spending about 6 days of your salary, and for the lowest price generic, it's 2.2 days of your salary. The last point was that affordability of treatment was significantly lower in Pakistan compared to all other countries studied, including India, Egypt, Lebanon, and China, and many other countries. So just on this point, I wanted to share this data from the same paper. This is obviously done in 2019, so prices may be a little different, but just to have an idea of the prices. This is aspirin, bisoprolol, atenolol, amlodipine, enalapril, losartan, atorvastatin. These are the prices for a 30-day regimen on this dose. So 10 milligram of bisoprolol per day for 30 days. These will be the prices. And this is again the number of days of wages which you have to see. So if you would see that if you would be taking an aspirin and a beta blocker and ACE or ARB and then an atorvastatin, you would be spending about 4,000 rupees or 3,000 plus for a month's treatment, which is about 3.5 or 4 days of your salary. But more importantly, it will be, this is something eye-opening for me. I found this data from Economic Survey of Pakistan that on average food basket, which would have enough protein as per recommendation, would cost about 3,000 plus for one person for a month. So this does not include the current inflation and current price hike, which is happening almost every day. So even if we take it as 3,000, it would mean that you would have to make a choice whether you want to be eating or whether you want to be taking your medication for cardiovascular disease prevention. So I don't know. Choice, I suppose, would be if I would be making a choice would definitely be towards taking the food rather than the medication. So this is what is driving the low usage of medication, even in patients who already had a heart attack or a stroke. So we need to be thinking of these points also and make sure that, I mean, one of the points which we had a presentation 2 days back, and KPK's health minister was the chief guest, and he did talk about the Sehat card, and Sehat card obviously is a game changer in healthcare. But I think one thing which we have to present to them is, and my suggestion to them would be that out of the total available amount in health card, maybe a certain percentage should be reserved for medication for chronic diseases rather than just an acute care. So maybe 10% could be shared, because that's how we can be sure that people are taking secondary prevention therapies and not just coming back for another MI to the hospitals and using up their Sehat card. So this is what WHO also says. I mean, the drug therapy for control of diabetes, control of hypertension and dyslipidemia is a best buy for WHO. Best buy would mean that it is very cost effective, even in low resource settings. And this is what we need to present to the government to make those changes so that these therapies are affordable to our population. In this slide, I think another important point which I want to make is that what they talk about is total risk approach. And this is another point which I want to make in my presentation, that it is not just that you see that blood pressure is high and that is where you start medication, or cholesterol is high and you start thinking of adding medication or not. The decision on starting therapy should be based on total risk approach or a global CVD risk assessment, because we know, and this is from WHO Heart's technical package for CVD prevention. The last version was 2018. On hypertension management, there was an update in 21, but not on CVD prevention as a whole. So it does say that using this global risk assessment for every individual in a population or an individual level, it is a cost-effective way and better than just starting therapy on its own. So how do you do risk assessment, a global CVD risk assessment? There are risk calculators available. I've just mentioned 3 here. There are more available also. One is an ESC, which uses score 2, then American or ASCVD risk calculator of ACC-AHA. And then there are also WHO risk assessment charts. WHO risk assessment chart is my favorite here, because this is the only chart which does say that they are also for South Asian. So they are, I mean, risk assessment charts for various regions of the world, and it has South Asia also. Whereas ASCVD, when you enter you as a South Asian, it would say that our calculator does not calculate improperly for South Asians, and South Asian risk may be significantly higher than calculated on this calculators. And same is for ESC. ESC has risk calculated charts or for various countries, but not for South Asia, including Pakistan. The other limitation, which is also for WHO chart, is that the risk assessment chart only starts after the age of 40 plus. And we do know this is a limitation, because we have seen that significant number of people get an MI before the age of 40 in our population. But this is something which we have to study, and there is now a study going on through the initiative of Professor Dr. Bashir Hanif, where we will be studying our young population, and we may be able to make a new calculator for our under the age of 40 population. But until we have that, we should be using one of the risk calculators. In ESC risk calculator, we have this risk categories, ages, risk categories, and then we have the chart as we've seen. I am not going to go through the how you do it, but this is available online. And the point here, there are 2 points about these which I wanted to make. One is that once you know that the particular individual falls into a category where you need to think of starting medication, you have to also think of the other comorbidities, frailty, patient preferences, and then decide what you need to do. And certainly, I mean, patient can move himself to a lower risk category, like just by stop smoking. The 2 points which another 2 3 points which I want to make about the ESC guidelines. This is a point that in young, apparently healthy people under the age of 70 who are at a very high risk, ultimate LDL goal should be 55 or 50% reduction. For those who are at a high risk, the ultimate LDL goal is 70. Then I think over the age of 70, it is a class 2B indication. You may consider starting medication on a overall individual basis, whether you think patient is at a very high risk. Under the age of 40, they do recommend in certain categories, if you have type 1, if patient has type 1 diabetes or type 2 diabetes with the target organ damage and their LDL is above 100, then one can consider starting under the age of 40. This is according to ESC guidelines. WHO risk chart, which are my favorite. There are 2 types: laboratory-based and non-laboratory based. The non-laboratory based obviously is useful where you do not have access to lab information or lab data, and it could be useful at a population level to find out people, those who are at high risk. Then they can have a laboratory assessment, so it becomes a cost-effective strategy. This is what would you do in a non-laboratory based risk assessment: age, sex, smoking status, systolic blood pressure, and BMI. And you find your person on which color he hits. So the risk would be according to that, 5% to over 30%, depending on their the profile. Laboratory-based risk chart will include total cholesterol and diabetes, where so it's a separate chart for diabetics or non-diabetics, and then the same way you would calculate the risk. What would you do once you have calculated the risk? This is again according to WHO. If the risk is less than 10% for 10-year risk of CVD risk, then obviously, I mean, your advice on diet, physical activity, and then follow up. If the risk is 10 to 20%, same advice. But if blood pressure is over 140/90, then consider medication. If risk is over 20%, then if blood pressure 130/80, add medication, start statin. And targets, we have already talked about what target we want to have. In certain individuals who are very high risk, you can consider drug therapy straight away. Those who are already had an event, cardiovascular event, or those who have target organ damage like albuminuria, retinopathy, or left ventricular hypertrophy, or those with a persistent blood pressure of over 160/100 or a total cholesterol of over 320, you can start drug therapy straight away. Okay, I think that's my summary. I think I'm finishing. I had message from Professor Hafiz that I have to stop, so I think I will be on time. There's no question that ASCVD prevention remains undisputed, and it should be delivered both at general population level and also at individual level. And at individual level, you have to have their global risk assessment, and then you make decision on drug therapy and set targets for them on cholesterol lowering or LDL cholesterol and their blood pressure, whereas lifestyle advice would be for everyone. I think that's it. Thank you very much. I would stop my share and back to Hafiz.
Excellent talk as usual, Professor Khawar. And as I said before, that this is beyond what books offer you. And let me add another sentence to it, that talks like this not only make you a good academician, a researcher, but also make you a good human being as well. That you also think about your patient's sufferings, which Professor Khawar enlightened us about this thing. So can I go to our panelist, Professor Ishaq, if you can kindly unmute yourself. Professor Ishaq, we all know, has such a rich experience in cardiology. He's a living legend. And if you could please unmute yourself, Professor Ishaq. Okay, while he is trying to unmute himself, can I ask Professor Suhail Aziz, Major General Suhail Aziz, would you like to give some comments? I've got a couple of questions. One question is from Dr. Azhar Khan, and that is risk factors at a younger age in South Asian. Is it not genetic? Professor Suhail Aziz. Maybe Professor Ishaq now is unmuted. Can you answer this question?
I am unmuted now.
Okay, can you answer this question, please?
First of all, thank you very much, Hafizullah, and Professor Suhail Aziz, Khawar Kazmi, all of you, my regards, and thank you for an excellent talk, Khawar. Sorry, what is the question?
A question is risk factors at a younger age in South Asian, is it not genetic? Because the question Khawar asked was, yeah.
Yes, I think it's genetic, beyond doubt. South Asians have got a very high genetic predisposition to cardiovascular diseases, diabetes, central obesity, and insulin resistance, metabolic syndrome. So I think he has listed a number of risk factors, but I think the one most important risk factor is genetic predisposition. So South Asians have got lack of protective factors and abundance of risk factors, you see. So that combination, because they lack some of the protective factors like physical activity and some other factors that protect against CVDs, and they've got abundance of risk factors of CVD like diabetes, hypertension, and central obesity. So I think there's no doubt that genetic predisposition is the most important aspect of younger age involved in cardiovascular events.
Thank you. Suhail, if you...
sorry,
yes.
I have to kind of just make a little point here, because this was one of our MCQs, and so people will take it wrong then, because so INTERHEART did not suggest this, which we, Professor Ishaq is mentioning. INTERHEART did say that 90% of the risk of having a younger age or AMI under the age of 40 is can be explained on the traditional risk factors of dyslipidemia and all the other risk factors, rather than the genetic predisposition. So genetic predisposition may be playing role within these risk factors, but the risk is 90% of risk is explained on dyslipidemia, blood pressure, high blood pressure, hypertension, diabetes, abnormal waist-hip ratio, tobacco use, lack of use of fruits and vegetable, and poor physical activity.
Thank you, Khawar, for correcting. I think I spoke in general that genetics are very important in South Asia.
Agreed.
Yeah, I think, but the point is, let's not blame genetics for everything. I think it is the collection of those risk factors,
exactly.
Which is something in our hands. We can identify them, and then we can target them. Furqan, can you please unmute Professor Suhail Aziz?
Sir,
there's one. Oh, now he's unmuted.
Yes, Assalamu alaikum. I've finally been unmuted. I'd like to thank Khawar Kazmi for a very wonderful lecture, and it's very informative, educative, and it targeted a lot of audience. A word about genetics. You know, in the Nature, it came out that the population in this part of the world actually migrated from Central Asian republics. And when they crossed the Himalayas and the Hindu Kush, they were like uh, surviving on 200 to 300 calories a day. And so we are actually descendants of people who are used to living on a few hundred calories a day. And when we think of a diet which the Americans suggest of 2,000 calories a day, that doesn't really agree with us. There's another very scary study of 300 to 350 cardiologists and cardiac surgeons in North America of Indo-Pakistan origin who were put on preventive medication and statins, just like the Americans were. And they found there was no reduction in the incidence of heart disease, and they did not demonstrate reversibility. So clearly, we are a different breed of people, and we have to focus on our own cells, and we need more data. But coming to what's been happening so far, it is a multifactorial disease. But the bottom line is that the cholesterol has to come down, and it's a very educative lecture, and it had a lot of lessons for all of us. And that is, not only do we need to talk about individual preventions and targeting and reinforcement by the physicians every time a patient comes to the doctor or any treating physician. But I think from this lecture, we not only need to now target the like we discussed earlier, the FCPS residents, but we need to establish a more stronger advocacy program for the government so we can talk about these preventive measures and at a wider level in the whole country, and collaborate with all the available societies and associations we have, and promote this concept of a healthy living, and thus induce reversibility, because we know that West has shown reversibility. They had a very high incidence, and now the incidence is coming down. But lately, the America has shown a rise again. So it's a continuous battle, and we all have to work on it. And I think we should sit with this committee right now and work on a program behind the scene on how to promote a healthy living. But
Excellent.
one thing is for sure, that lower the cholesterol, lower it is. And we all have seen these WhatsApp coming in that, there's been a hoodwinking on part of everybody that cholesterol is a bad thing, but actually it's a good thing. Well, in those SMSs, there's one basic thing which one needs to point, and it's the high glycemic index carbs, which are bad for you. Because when you suddenly take those high glycemic index carbs like white flour and bakery stuff, they suddenly shoot your your sugar level, which are stored as cholesterol. So it clearly needs to be understood, and maybe we need to have more lectures on healthy living, and that needs to be reinforced at every level for improvement in the outcome of our cardiovascular patients.
Professor Hafizullah, can I just make a little point?
We have passed our time, so yes, brief comment. Yes, please. Go ahead.
Yes, I think in the context of genetics, I agree with our. Sorry.
Can people mute their mics, please? Yes, please carry on.
Yeah. So I think as far as genetics are concerned, INTERHEART study has shown something. But about 20 years ago, more than 20 years ago, there were studies done in UK, people of Asian origin becoming heart patients and victims to a heart attack. And they found a very distinct demarcation between Asians living in UK and their counterpart white population there. So I think genetics is an important aspect. And we see a lot of people becoming victim of heart attacks without any obvious risk factors sometimes. So I think whereas the risk factors are very important and they should be modified, and I think we have to target, we can't do anything much about genetics. We have to target on the risk factors that can be modified. And yes, cholesterol is one of the most important risk factors which needs to be modified. And I think Khawar Kazmi has made an excellent presentation of how to actually go about it. I think it needs two-pronged strategy, targeting the community at one level and targeting the high-risk patients, I think, is the most important aspect that can be practiced in practically talking. We can only handle the people who have got the disease or risk factors, only they can be sensitized. Otherwise, the population at large, becomes very insensitive or not interested in this thing. But I think we have to keep on trying, and preventive cardiology, I think, has a major scope, major responsibility to do that. So I think it has to be a two-pronged strategy, high risk patients on one hand, and the population at large on the other hand. And the cardiac society and all of us have got a responsibility to attack both sides simultaneously.
Thank you. We have passed 3 minutes past our time. I'm very grateful to all the participants. There is a barrage of questions. And let me just assure you that all these questions, especially about the treatment, will be answered in the next talks to come. So please stay tuned. We love to have an active participation. And the beauty of a lecture is that it creates so many questions. And Khawar Kazmi has been able to sensitize, raise this issue very nicely, and has been able to create so much of interest. I'm very grateful to Farmivo for offering this opportunity, extremely grateful to Pakistan Cardiac Society President for actively participating. And stay tuned. Next week, we will have talks, same time at 9:30, hosted by Professor Amber Ashraf. And the week after that, as I just shared with you, we will have part 2 of this lecture, and then we will continue. We'll have a 6 lecture module. Apna khayal rakhein, and salam to all of you. Thank you
very much.
Bye-bye.